very much for all the speakers for great presentations. I would like to welcome everybody to the final session for question and answer. And I'm sure all this great presentation is going to generate a lot of questions. I would like to ask also Dr. Junaid to join us. So we will start with the question to Dr. Hafis. A really great project for quality improvement in decreasing the infections in NICU. You present the outcome of your quality improvement in terms of number of infections per 1,000 admission. Since you did a lot of work on improving the compliance with a infection control for inserting the central lines, would that be better if you add the infection per 1,000 central line days instead of 1,000 admission?
We look at both. We have that data separately when we look at CLABSIs, and that has come down as well. I didn't present that data that is available, but our CLABSIs are far and few in between, thankfully now. We've been going up to 6 months without a CLABSI at a time, though we've had a few in the last few months because of the particular population of babies we had. But that's come down as well. We look at that regularly, yes.
Okay. Thank you. We can alternate questions to all speakers, so we can. We have a lot of questions to Dr. Dustin about the COVID-19. One question is that in your data, did you find that maternal infection with COVID-19 during pregnancy cause more premature labor or premature death, premature birth?
That's a great question. We did not specifically look for that in our local studies, although there was another group in the Penn CHOP system who did analyze that using a pre and post-pandemic cohorts, and they did not find a difference. Other studies have found a difference in either preterm birth or stillbirth. I think it's going to be some time before we really understand that, and I think there's probably going to be a difference based on the region or the cohort studied.
Okay, great. Thank you. For Dr. Holly and Dr. Natalie, it's great to know about the fetal surgery. Unfortunately, fetal surgery is not really a standard or available in many places. So my question to you about fetal surgery in severe congenital diaphragmatic hernia, if we would refer the patient to you in utero, what's the optimal gestation age that we're going to send to you? And what's the criteria to define that this is a severe or incompatible with life to do a fetal surgery? Do we look at the head or lung to head ratio? Do we look at liver presence in the chest or MRI finding? What's the criteria to refer?
The criteria is really the observed over expected LHR by the trace method. But that's can be a user dependent, that can be a hard, thing to always get the same number to get it right. So multiple measurements, and then looking at all the sort of surrogates that go along with that. So where's the liver? Are there any other congenital anomalies? So absence of other congenital anomalies, the liver up, and then the observed over expected less than 25%. It's also, if you're looking at the MRI, do you see any lung at all on the left? Is there severe mediastinal shift? Like if you're not sure of your measurement, those are some of the surrogates you could use. So those are really the criteria.
What's the gestational age that we?
So you would want to get the patient. You would want to get the patient to the center that can do this before 27 weeks. So and we found that we really feel good if we can see it be low multiple times. Like, for us, it's not just, one low measurement, let's go, because you'd hate to commit them to that whole line. So really, we love it if we can see them multiple times. And it's our center does it in Europe. It's Dr. Depressed. He is really the master of the universe in terms of this procedure and their outcomes. And so he's a great resource as well. And he's very, very generous with his expertise.
So what's is it genetic testing is mandatory before, or are you just looking at the malformation? Okay.
Mandatory.
In terms of amniocentesis practice or CVS? Okay.
Yeah, usually we do a microarray.
Okay, great. Thank you very much. And for Dr. Eric, in our area, we cannot really send babies on caffeine at home because we don't have available home apnea monitors. So we have to keep the babies in the hospital for a certain time after we stop the caffeine to be able to discharge them home. But my question is that to you is, when you talk about evaluating babies' desaturation period, do you look at number of events per day, or you look at histograms and you look at a percentage of saturation below 80% for the 24 hours?
So the data that we're collecting, I think that's a great question. The data that we're collecting is really based on the histogram for the purposes of seeing whether later caffeine works to shift the number of events below a certain 85% or 80% saturation. And I think that to address the first concern about using home caffeine and needing to home monitor, I don't think that's necessarily clear. In the MOCA trial, the babies are actually being sent home without a home monitor and just keep receiving 28 days of caffeine once a day at home. And I think that the justification for that in the study was that we felt that this was a relatively low risk population for having apnea at home, and being treated for a full month would get them to a postmenstrual age that the risk of the caffeine being stopped and having them have breakthrough events was very, very low. And it's also true with the ICAF study. The babies are being sent home with a study oximeter, but that's masked to the caretaker. So it's not serving as a monitor, it's just a recorder. And so I think that it certainly is possible in certain categories of patients to send them home on caffeine without a monitor. And the other thing I would say is that because caffeine citrate is commercially available and is quite expensive, in the ICAF study, we're formulating a caffeine base, compounding it ourselves in the pharmacy. So it costs literally pennies per dose. So it's another way of approaching this problem if you decide that that's what you want to do.
Great. Just a word of caution for our audience. We have 780 colleagues are logged on right now to watch us live. So just a word of caution for our UAE audience. We have to follow the local guidelines for discharging home with caffeine or after caffeine, how many days according to your regulators. That might be different than the US criteria.
Yeah, we're a little bit more of a free-for-all, Dr. Aiman. So as I said, there's a lot of variability. So I'd love to see your data about how consistent you are if you have national guidelines.
Yeah, great. And Dr. Junaid, do you have any questions?
Yeah, I have a lot of questions, but I start with Hafis. This is my debate with him all the time. 14 days PICC line, and then you recommend remove it and put a new one. I need a comment on that, and I need a comment from our CHAPS colleague also.
Yeah, so as I said, when we looked at the evidence, there were two studies we relied on. There was a large study from the US, I can't remember the author now, from a network of around 3,000 babies, which showed no difference depending on the duration. Whereas there's another smaller study from Adam Milston, which said lines beyond 14 days, the risk of infection proportionally goes up. So I think it all depends on the environment we work in and the setup we have. And when we looked at our own data at Cornish, because of the peculiarities of the way we work, that was borne out. Our infection rates go up once lines lasted more than 2 weeks. And once we implemented the policy, it was a package of measures. It's very difficult to pinpoint whether that was the only thing which contributed. We did see an immediate downward trend in CLABSIs as well as general infections. That's why we kind of stick to that. We are a bit nervous to kind of change it at the moment because we're still nowhere near ideal in terms of flow space, sensors, and other things. But certainly something which we're looking at closely as the evidence evolves.
Yeah, sure. Because we don't have CLABSI that much, and we have very small babies in my previous work. So I don't change, and I have no problem even with 24 meter if they are very sick and required more than that. Dustin, I have a question for you. What about, I know you mentioned about the COVID vaccination in a pregnant woman. Can you please elaborate? Because there are a lot of people WhatsApp me, they want to know, and they want to know in two ways. That if a lady get it, pregnant woman get it, a Sinopharm, so she has to get the booster dose, or if she is in the late pregnancy now, so she has to get, the first dose, the second dose. What is your recommendation at this point when the COVID, I think, going down and this thing?
Yeah, that's another great question. I think the recommendation for the booster dose is so new that I don't think there's any clear recommendation for the pregnant population at this point. I think we will probably have some information or recommendation from the CDC, at least for the US population, in the coming weeks or months. I think your second question was about the timing of the vaccine.
Yes,
is that right?
yes.
Yeah, that's also a great question. I think from what we know about data so far, and also from other vaccinations in general, that you need at least a few weeks for the pregnant patient to create the antibody and to efficiently transfer the antibodies to the newborn. And so I think my recommendation would be at least a few weeks before delivery, although so far the VSafe registry data from the CDC have shown that even vaccination in the first and second trimester is safe. And so I think it's really up to the pregnant patient and her provider to decide on the best timing.
Okay.
And one related question about, I know it's a little bit out of topic, but since we're in influenza season right now, so how about giving influenza vaccine to the mother in the same, what's the time frame to give it with the COVID?
Yeah, so the early recommendation was to keep other vaccinations separated by at least 2 weeks. And I think that was primarily to determine if there was any adverse effect or complication to not gray the picture of what was the cause. My understanding is that that is not a clear recommendation from the CDC at this point. And so I think providers are mostly still using that advice, although I don't think that's a clear recommendation. And so I think it's, again, up to the healthcare provider, but I don't think there's any contraindication to giving, flu, Tdap, COVID, second COVID at the same time.
Okay. Dr. Natalie and Dr. Holly, I am a neonatologist, a simple neonatologist, so I have a very simple question. What is your recommendation to take the baby for the surgery? When you say that this baby is stable enough for the surgery for congenital diaphragmatic hernia, because this is a long debate. As a neonatologist, we become anxious. Oh, now baby is okay. Take to the operating room, fix the problem. We will take care of later. So, what is your criteria that this baby can now go to the surgery?
So if the baby's not on ECMO, we almost never regret waiting until pulmonary hypertension resolves. So no spells, sturdy, tolerating care, FiO2 weaned down to at least 50%, not in this spiral of escalating care. The surgery doesn't cure that kind of a situation.
Mm-hmm.
It sort of just makes them necessitate ECMO if you sort of drive in too soon. So I don't know, we always go back and forth with this, and it's a very much a joint.
We're always trying to decide. It's not the numbers on paper, right? We will check a BNP. We will look at the echo, but we use that in conjunction with how the baby's doing. So we'll talk about it all the time. They're tolerating diaper change. They tolerated a suction. Someone turned the lights on and they didn't have a shunting spell. We really like to have that shunting kind of melt away, really have that pulmonary hypertension. They're just far more stable and robust, but it's not like there are 10 rules that need to be accomplished. It's sort of big picture team discussion. Who are they? Where were they? Are they ready for the challenge of surgery? And so, if that answers the question.
Yeah, we have one related question about ECMO. If the baby was very sick to go to ECMO and stayed on ECMO about 14 days, then after the 14 days, what's the decision? Would you go on ECMO longer time, or would you do surgery on ECMO?
We usually try to make the decision about, once we go on ECMO, we try to make the decision about whether or not we're going to try to get them off ECMO really early, and it depends on how they were before they went on. So if they were terrible before they went on, we're going to try to fix them on the early side, and so we're not going to wait 2 weeks. But if they looked pretty good and it was just purely pulmonary hypertension, cardiac dysfunction, then we're going to wait for that to get better. And then there's all kinds of tricks that Dr. Rintoul has for getting the lungs open, for keeping the fluid low. And we really don't give it a time limit. So it's sort of a week-to-week assessment. I think our world record is, about 5 weeks on ECMO. But we don't we don't stop at 2 weeks just because it's 2 weeks.
Yeah, no, it's true. We look to see why they're on. Is it because the liver's up and the bowel is up or dilated and the tidal volume is like 2 mLs per kilo? Then it would be like, well, we have to start then to plan for the surgery to try to get some space to come off. If the lungs are wide open and the tidal volumes are 4 per kilo, maybe 5 per kilo, but every time we wean the flow, that pulmonary hypertension rears its ugly head and then they're shunting and the right heart is struggling, then we'll start them on that treprostinil and start to ramp up over several days and then see how they respond. And so it's, do they need a repair? Do they just need more pH meds? Do they need more time? And it's always, Dr. Hedrick was saying, time is the best medicine, right? Sometimes they're not ready at 14 days, but by 21, they're like a totally different patient. So it's again, who are they at that moment? Are the lungs open? Are they edematous? Is it pulmonary hypertension, or is it the size of the lungs? Is it the size of the liver that's impacting their whole picture? So we always say every phenotype is so different. We treat each baby different. But really, there was an early paper by our colleagues in Pennsylvania that looked at pulmonary hypertension, and they didn't see any survivors if they had significant pulmonary hypertension after 6 weeks. So that's sort of one of our things. We think, we start thinking by 2 weeks, then by 3, by 4. We had one patient that survived at 5 weeks on, but it was significant pulmonary hypertension. And so, we try to look at the whole picture and try to assess what piece of it is it that we're treating and what needs to be done.
Yeah. I have one question for Dr. Eichenwald. Dr. Eichenwald, I know your topic is when to stop the caffeine, but I want to discuss among all the colleagues, Hafis, Dustin, and yourself and Aiman, that what is the dosage, how maximum dose you use? Yesterday we have Dr. Clary and he talked about 20 milligram per kg. What is your experience to use that high dose? We never use here, and I think same with Aiman. Here is working with us here in Abu Dhabi. So, what is your experience?
So, no, I think that's a great question, Dr. Junaid. I think that we only use up to 10 milligrams per kilogram per day. We really stick with what was studied in the CAP trial, and I think that there is some controversy. There are some studies, some randomized trials that demonstrated that Dr. Flannery, I'm sure, reviewed that the 20 milligrams per kilogram as a daily dose does have an effect on a decrease in apnea and maybe increase in extubation success. But my concern with that is that the safety of that has not been studied. And it's primarily being used in the very, very preterm babies, which again were underrepresented in the CAP trial. So I think that our first approach to this should be what's been proven to be safe, and that 10 milligrams per kilogram has been proven to be safe. So we don't go above that. And I will say that Dr. Barbara Schmidt was our colleague here at CHOP for a decade. And as I'm sure as I listened to her talk, she made it very clear that she's on the side of evidence-based medicine. And right now, I think the evidence would support the drug doses that were studied in the CAP trial and not higher. So I would be hesitant in my own practice, and I know that my colleagues at CHOP and Penn would be hesitant to go any higher than that right now without further data on safety.
One follow-up question about the dose. Now, if you have a baby on 10 per kilo and you decided to stop caffeine, would you go down to 5 first, or you go just 0 from 10?
Personally, I would just stop it altogether. I mean, I think that the drug levels are going to be slightly higher on 10 per kilo than on 5 per kilo. Some clinicians decide what they say to outgrow the dose, where they allow the dose to become lower and lower on a per kilo basis as the baby grows, which I think is an okay approach as well. But I don't think there's any real data that you need to wean caffeine. If you're ready to come off, I would just simply stop it. And then you have the advantage of monitoring for spells. You'd expect them to increase a little bit afterwards. But then as the drug disappears and the baby gets older and more mature, that the apnea should resolve.
We have a question for Dr. Natalie and Holly about if a neonatologist decide, or actually fetal maternal doctor decide to refer the patient for possible fetal surgery, would it be possible to be evaluated by telemedicine, or the patient have to come to Philadelphia?
I think ultimately, if it was a serious referral, like we would be happy to review the images, happy to have a conference, but for a true evaluation to be sure they were a candidate, we can't really promise anything unless it's in person. So we're happy to review images, to consult with people ahead of time, but it's not until it's hands-on, it's not a true sort of recommendation.
But we have been doing a lot of teleconferencing, especially after COVID started. We really ramped that up, and very frequently we do have, group meetings with referring places, and whether it's the moms prior to surgery, or even for, help with babies down the road. We've been doing a lot of that too. So if anybody needs anything.
Aiman, I have one question for Hafis. Hafis, we discussed a lot, and I discussed with Dr. Poland and one time with Dr. Hedrick also. Let's say you have you suspect CLABSI. Did you culture from the central line, and did you send the catheter tip for the culture?
We don't do, the central lines we put in are 26, 28 gauge lines, which rarely bleed back.
Yeah.
So unless it's a femoral line or a Broviac, they don't get blood back. So if we have a Broviac line, we certainly do a culture from the central line. Otherwise, it's peripheral cultures, which we do. And if we suspect a line is infected, we don't send tips routinely. If you're just taking out a line because it's time to take it up, we don't send it routinely. We don't find it useful if the baby is well. But if we suspect, we don't know where the source is, and we've taken out a line in an infected baby, sometimes we send it, but not as a routine.
Yeah. Dr. Hedrick, I don't know if you remember, but it's actually me, Aiman, you, and Poland, Dr. Richard Poland discussed this. Did you send for diagnosing the CLABSI central line culture from the central line? Because Dr. Poland said the two different peripheral line you can send, peripheral culture you send. What is your practice and experience?
So I'll defer that question to Dr. Dustin, since he's an expert on neonatal infections.
Okay, Dustin. Sorry about that. I didn't know that.
I can tell you what we generally do, but
my apologies.
we usually at CHOP we send a central line and a peripheral culture, both. But I think Dr. Dustin can go through sort of what the other official recommendations. And as you know, I would never cross what Dr. Richard Poland says. But sometimes our practices are a little different. But
sure. That's why I raised this question.
I'll let you respond to that, Dustin.
I think he's listening to us, so.
Yes, Dustin. Go ahead.
I'm not sure there's an official recommendation, but I agree. I think the best practice would be to send both. Unfortunately, in some scenarios, it's just not possible. If you have, a 23-weeker, and you're not able to draw back from the line, or you're not able to get a peripheral stick, or you only get a quarter cc from each, you may just have to send what you can get. But I think in an ideal world, you'd send from both sites, aerobic and anaerobic, but I just don't know that that's always feasible.
Okay.
But we all, I think, agree that we don't want to send the tip of the catheter. It's a big line removed to a culture.
Yeah, that's
I think we all agree. I think we all
unusual
agree
for us to do that.
Great.
I
So I got a signal that we have only 2 minutes left before we close. So I will open the floor for anybody who want to ask questions, because we're asking all the questions. But if you have any question to ask anybody here, will be great.
Can I ask a question to Dustin? Thanks for the wonderful talk on COVID. We've done a fair bit of work at our center as well. One of the things, we haven't published this data yet. Anecdotally, what we're seeing with the second wave, where the Delta variant was more prevalent, we were seeing much more sicker moms, much more placental pathology. Is that your experience as well as compared to the first wave?
Anecdotally, absolutely. I think early on, there was a lot of fear about how the virus would affect pregnant patients, but it definitely did not seem to be as severe as we had feared, as with influenza. But just anecdotally, and I don't have research data to support this, but over the late summer, especially in August, at our own center, we had multiple cases of pregnant patients admitted to the ICU, mechanically ventilated, transferred for ECMO. And that's certainly a national trend in the US, which again was the cause for that urgent health warning from the CDC at the end of September. And I wanted to make one clarification about the timing of the COVID vaccine that I should have mentioned. The timing recommendation for influenza is any time during pregnancy. And that's not just to optimize antibody transfer to the newborn, but really to protect the pregnant patient, because we know that pregnant patients are at high risk for severe influenza, as opposed to Tdap, where the Tdap recommendation is for later in pregnancy to really optimize antibody transfer, because pregnant women don't get sick from pertussis. But as this Delta variant has changed our understanding of how COVID-19 affects pregnant women, I think the recommendation will probably be to get it as soon as possible, and certainly ideally before pregnancy, to really protect the pregnant patient.
Anybody have any questions?
Thanks.
I would just like to compliment Dr. Hafis on his work. I did say that in the chat, but I think that quality improvement extends certainly internationally, and a lot of the work that he's done in his unit is work that we've all done in our units as well. So it's gratifying to see that it can work as well all across the world. So that's I think a lesson for the people listening here, that you really can make a difference and improve the outcomes of the patients that we take care of.
Maybe we can do a multi-center project together to
Yes, exactly. And Dr. Hedrick, he was my competitor. So he did this transformational event and he won the first prize and I come second. So I'm really, but he's like my younger brother.
You have to be second sometime,
Yeah.
No, very well done, Hafis. Very well done.
Now, since 3 of the 4 speakers are from CHOP, I don't have any questions for them because I can see them on a daily basis.
Okay.
But,
very good. Thank you
but I
very
think
much. We really enjoyed this session. It's really great closing for the conference. And as Eric mentioned, we will hope to see you, and inshallah we'll see you next year, mid-year. I'm not going to give you the exact date yet because we haven't decided, but mid-year we're going to have a hybrid conference. So we will be happy to see you in person, inshallah. Thank you very much. Appreciate your sharing with us all your knowledge and wisdom, and then we will see you soon, inshallah.
Thank you.
Thank you.